Okay, good morning. I'm wondering if we want to wait just a minute or go ahead and get started.
Go ahead and get started, Catherine. Thank you.
Sure. Okay. Hello, everyone. My name is Catherine Chalikian. I am a statistician at the Johns Hopkins Applied Physics Lab. Thank you for joining our session this morning or today, depending on where you are in the world. We have two great speakers today sharing their work on quantitative approaches to safeguarding child welfare. Our first speaker that we have today is Dr. Svetlana Yampolskaya. Ooh, almost messed that up completely. Yampolskaya, who will discuss the use of big data and subgroup analysis to explore trajectories of substance use among youth in the child welfare system. So without further ado, I will share with Dr. Lana.
Yeah, I'll try to share my screen. Well, share. Hello to everybody. My name is Lana Yampolskaya. I'm from the University of South Florida. And today I'm going to talk about various approaches to analyze child welfare data, and specifically data that had been previously collected. Well, recently researchers use a new term, it's called big data. And basically it's a concept that describes any large volume of data that produced by various entities on day-to-day basis. We all know that researchers now use administrative data sets, or mass media data can be analyzed, for example, using content analysis. And there are surveys that don't have specific research question in mind, but the purpose of these large surveys that have been recently very popular is to get information about a specific area of interest. For example, child and adolescent health, or substance abuse among adolescents and stuff like that. This big data, or data that had been previously collected, attracted a great deal of attention because for several reasons. One of the reasons is its cost effectiveness. We can save a lot of time and money because there's no need to collect data. The data are readily available. Another reason is sample size. As you know, researchers often struggle with a sample size to detect the effect, but typically this administrative data set, so this big survey, they have a huge sample size, so we don't have to worry about whether we can or cannot to detect an effect. The data usually are very comprehensive. So if a researcher wants to reanalyze this data and focus on specific subpopulation, again, we don't have to worry about power. We know that we will have enough big sample size to answer our research questions. And finally, these data sets can be used to answer various research questions. Of course, there are some disadvantages. I wouldn't go into it. I just mentioned one. Often when you have a specific research question in mind and one like additional piece of information, but it's not there, and therefore you just cannot answer this specific research question or cannot include this variable in your analysis. These big data sets can be analyzed in different ways. One very straightforward data analysis, just an individual level analysis, we all know. We just look at the predictors, for example, or characteristics of the perpetrator, and look if these characteristics are associated with placement of their children in child welfare out of home care. There are various research questions can be asked this way. Another way to deal with that and specifically for child welfare in the United States, every state collects data related to child welfare system. And states usually are pretty big and they have multiple counties. So we can use county as a unit of analysis and look, for example, as a county crime rate and how it's related to county child maltreatment rate. Or a multi-level analysis can be used, and we can look at how county level predictors, for example, county poverty level or county crime rate, actually affect a specific individual and it's his or her involvement with the child welfare system. And finally, longitudinal analysis are readily available because this data usually are collected every day, every month, every year. So we can track a specific individual and what happened to this individual over time. The other thing that I want to mention regarding administrative data sets or data that had been previously connected, we can create a new measure based on the data elements that are available for us. I give you an example that I've used in the past. In the child welfare data that are available in the United States, specifically in Florida, there is information about specific allegation of abuse, for example, whether it was sexual abuse or physical child abuse, or it was a threatened harm. It was information about how many specific child maltreatment allegations were applied to a specific individual at a time, and then how many times that individual was involved with the child welfare system. So anyway, based on this information, we created a new measure and we called it severity of child maltreatment. Again, I wouldn't go into details, but there are manuscripts available if somebody is specifically interested. Another approach to creating a new measure is to use data elements or find the data elements that are similar to those data elements that are readily available in already existing measure. And again, an example I want to give is an attachment measure. It is a valid measure and widely used, but we can find similar elements if they are available in the data sets that we're using and recreate a similar measure. And we know that approximately it will hopefully it will measure attachment. And finally, we can use time to event or create time to event variable, for example, recidivism or recurrence of child maltreatment within 1 year or 6 months, it depends. As a big data set that I've been talking about, I'm going to use the example of National Survey of Child and Adolescent Well-Being. And that is a national longitudinal probability study of families involved with the child welfare system. And again, this longitudinal study was designed to collect or get as much information as possible about child welfare and who is involved and anything that we can possibly find in this data set. But our research portion was specifically focusing on substance abuse trajectories among adolescents. There is some information in this data sets regarding substance abuse among adolescents. And like I mentioned, this is a longitudinal survey, and they ask adolescents whether they use alcohol, marijuana, and cocaine within the last 30 days at each time point. And we just kind of did the trajectory analysis to see what happens over time to these adolescents. And the frequency of use of drugs was measured at 0. At that point, the person didn't use any drugs. To 6 indicates that the person has been using drugs for 20 or more days. This survey is based on a stratified 2-stage cluster sampling strategy and therefore required multi-level data analysis, multi-level modeling. And because we wanted to look at the trajectory analysis, we use multi-level latent growth curve mixture modeling to examine both longitudinal traits and various substance abuse trajectory. We wanted to see if there is specific trajectories associated with a group of adolescents. As a result of our data analysis, we identified two classes. The first trajectory class, we call it high stable substance use trajectory, and that included 91% of the sample, and it was characterized by very high initial substance use, but it didn't increase or decrease over time. It remained stable over time. And the second trajectory class, we call it rapid progression use, which include 90% of the sample and was marked by high initial use followed by even more increasing growth over time. When we compared two classes, we found out that compared to high stable substance use trajectory class, children who comprise rapid progression use trajectory class were 4 times more likely to have a history of physical abuse. Odds ratio was 3.9. And within the class, it looks like older youth who are Black youth with a history of threatened harm, or youth with internalizing behavioral problems significantly increase their substance use over time. On the other hand, high stable substance use trajectory compared to the rapid trajectory use trajectory, children who follow the stable substance use trajectory were more likely to be white, and within the class youth who experience neglect significantly increased their substance use over time. Well, this information was very available because it allows us to think about or create intervention that specifically addressed this group of adolescents. For example, we can, instead of providing intervention for everybody, we can create an intervention that focusing specifically to those group of adolescents with their specific issues. For example, we do know that rapid progression use class, that their increase in substance use is associated with experience of threatened harm, and it's possibly due to their intensified anxiety to the family context, and they use just substance as a coping mechanism, and therefore we can think about intervention that aim to develop positive coping behavior. If we talk about high stable substance use trajectory, we do know that the increase in substance use is associated with neglect, and it's probably due to the lack of attention and communication from their parents. And they just use substance use behavior as a way to be accepted, to become popular. And therefore, we have to develop intervention that focus on developing social skills and peer relationship. So this is references, and I'll be more than happy to answer questions if anybody has questions. I hope I am okay time-wise.
Oh, you're perfect. Thank you so much. That was wonderful. Just because we are on a tight timeline, our second speaker is Dr. Rameela Raman, who will be talking about her work with linked data. And due to last-minute travel issues, Dr. Raman is unable to be with us live, but she has shared her presentation, and so I will be presenting on her behalf. So bear with me as we get that up.
Hello, my name is Rameela Raman, and I'm an associate professor of biostatistics at Vanderbilt University School of Medicine. I collaborate with other disciplines across campus to answer the research questions, And today I'm going to talk about how we were able to link administrative data to inform policy and programs with our child welfare partners. So data linkage, specifically administrative data linkage, has been getting a lot of attention recently, particularly since it is considered a very promising approach to addressing the limitations of existing data sources. For example, in the child welfare system, one could link a child's administrative data regarding their education, birth records, etc., to their diagnosis that exists in the medical record system so that they have a complete picture of that child's needs. So one question most people ask is, why not just collect the data that you want in the administrative database in the first place? Why even try to bother linking it to different data sources? And the answer is that administrative data is primarily created for day-to-day operations. There are limitations on what can be collected and stored and how much, since that is usually dictated by a program's priorities and available funds. Also, some of the policy relevant questions that researchers end up being interested in come after the data has been collected, and so we have very little control over what is collected and how. However, using administrative data can end up being very cost effective for the researcher to use because the data is already collected and it is there. So when we take administrative data and link it to data from different sources, it forms something like a comprehensive database, which enhances our ability to ask broader questions. These sources that we are linking to the administrative database can be both publicly available sources of data, such as the census data, or it can be non-publicly available data, such as health records. Among the many advantages that there are in linking such data, one is that this data already exists, so why not use it? It is both cost and resource effective because one does not have to spend time collecting it or burdening the participants. It also leads to more accurate estimates of variables because of the way the data is collected. So this is an image that I like to use as an analogy when people ask why we need to link administrative data. As a researcher, if I only use administrative data to answer questions, I would get to see only the tip of the iceberg. In a child welfare context, we can say that this tip represents the number of children coming into custody. But when we look deeper into the water, that is link multiple sources of data, we are able to form a more complete picture of the actual problem. For example, when we link administrative data to population denominators from the census, we can compute the prevalence of child abuse happening in a specific county or state. Similarly, when we link it to opioid prescriptions in a specific county, we can associate child abuse with risk factors related to drug abuse, for example. So we know why data linkage is useful. So how do we implement this? Though it seems theoretically simple to link two data sets together, it can be very challenging and may require a lot of resources. So when we link data sets together, the first thing we need to think about is which level of linkage do we want to implement? Do we want to link data sets together that are comprised of individual level data? For example, do you want to link a person's birth record to their educational record? Or do you want to link an individual level data set to a geographical level data set? For example, do you want to link a person's health record to the poverty level in the neighborhood? So oftentimes decisions like these are driven by the research question. When you link data sets together, it is important that there be a common identifier between the two data sets that are unique to an individual. It could be something like social security number, a combination of date of birth and last name or geographical location, etc. Of course, that is the ideal situation, but there are probabilistic linkage methods that you can use when these are not available that I'm not going to talk about today. So now coming to a policy relevant question where we used linked data. Overprescription of psychotropic drugs has been a large issue in the child welfare system. So child welfare partners made it their primary goal to tackle this. The main question that was posed to us was, what is the prevalence of overprescribing happening in a child welfare system? And the concern once again was that many youth receive psychotropic medications with very little oversight. The second question was, would it be possible to identify prescribers who overprescribe? So questions like these are usually tackled using statistical profiling techniques. which is the process of comparing some quality of care with a normative or community standard. So when we say provider profiling, we hear it mostly in the context of medical care, where providers such as hospitals, surgeons, or physicians are evaluated. But you can compare processes such as time taken to a doctor or overprescription using similar methods. And the goal here was to use this analysis as an opportunity to have constructive conversations with the prescribers, understand what systemic issues we could fix, and not to reprimand these providers. So I'll start off with a few simple statistics to motivate this problem. There was a recent article that talked about how 1 in 4 adults now take opioids. That is, they receive long-term opioid prescriptions for non-cancer pain struggles with lifelong addiction. And many people have compared it to how 1 in 6 adults take psychiatric drugs. If you look at how many foster care children take psychotropic drugs, the answer is 1 in 4, which is an alarming statistic because that is equivalent to how many adults take opioids due to addiction. So just to make sure that everyone is on the same page, any medication that is capable of affecting the mind, emotions, and behavior is considered to be a psychotropic drug. So there is widespread concern that psychotropic drugs are prescribed to children in the United States at an alarming rate. Although it is every state's policy that psychotropic medications be prescribed and administered only when medically necessary, children in state custody are particularly vulnerable to overprescription at stunningly high rates, far higher than children in the general population. And there are two main reasons why children in custody are at risk of overprescription, far greater than children in the general population. One is because children in the child welfare system are there due to abuse and neglect. They have far more traumatic experiences and hence behavioral issues associated with that, which prompts a prescriber to write them a prescription. Second, prescriber medication is available right now on demand, and other services such as counseling, therapy, and appropriate treatment are not. When you don't have a choice, you often rely on what you have. That is something that prescribers have often said. And for children who come from a stable homes, they have a choice. Oftentimes, these kids do not. So some of these statistics presented in these slides are from around the United States regarding overprescription of psychotropic medications. So coming back to a research question, what is the prevalence of overprescribing happening in a child welfare system? It is important to first define what overprescribing means. And this was the big elephant in the room, or the big question that we had to tackle. How do you evaluate if a prescription was an overprescription and not? And it is important to understand that we are limited by the data that we have, and we do not have child diagnosis specifically. So we assembled a team of clinical psychologists, psychiatrists, pediatricians, and asked them to tackle this question. It wouldn't be surprising to all of you to hear that it was very hard for them to come up with an agreement on what an overprescription was. They all come from different disciplines and have different ideas on the role of medication. But when we looked into the literature, there was guidance released in 2012 by a federal agency on the appropriate use of psychotropic medications for children in the welfare system. Specifically, they suggested that certain prescriptions or prescription combinations should raise a red flag, and they defined red flagged prescriptions as being too many medications prescribed at one time, medication doses that are above recommended levels, or if a prescription is prescribed to a child less than 5, that can be considered to be an overprescription. So the next step was to obtain the data that was necessary to evaluate the research question. When we have administrative level data regarding the child, their age, gender, race, we were planning to link it to prescription level data from the pharmacy and neighborhood level data to obtain neighborhood level covariates that might be important to consider. So I'll first tackle how we link administrative data to geographic level data. As one expects, there might be many children from a specific neighborhood, and in order to link a child to the neighborhood, we need their address, which is collected in the administrative database. Once we have their address, we can use geocoding to obtain data regarding socioeconomic status or neighborhood level variables. Geocoding is basically the process by which we can assign a code, usually numeric, to a geographic location. So in health disparities research, geocoding means attaching the latitude and longitude to an individual address. And once these are obtained, you can answer questions like, what zip code does this specific point lie in? What is the percent of poverty there? What is the median income there? And by doing so, we can use a person's geographic location or address and estimate certain characteristics of a person based on characteristics of the person's neighborhood. It is important to remember that this is just an approximation, and this can be implemented though easily using programs such as ArcGIS, R, or even Google Maps. So by doing so, we were able to obtain socioeconomic information for these children from the census data, some of which were variables around poverty, median income, and so on. So we have administrative level data, publicly available data, and then comes our prescription level data, which comes from a pharmacy management system. The data is at a prescription level and consists of indicators of whether or not the prescription is red flagged or considered inappropriate or an overprescription based on the standard that I just mentioned earlier. So basically they were red flagged if they had more than 4 medications at any point in time, if any medication exceeded the maximum recommended dose, and if they were less than 5 years old and received any psychotropic medication prescription. As we can see, these classes are not mutually exclusive, because if you have 2 or more medications in the same class and they exceeded the maximum recommended dose for your age, then you would be red flagged under both categories. So for the sake of our analysis, we chose to focus on the outcome, which was whether or not a prescription had any red flags. For our analysis, we used over 1 year worth of data, which includes all prescriptions for psychotropic medications. And that amounted to us having data from about 4,000 children who received approximately 36,000 prescriptions, of which 75,000 were red flagged or considered to be an overprescription. So below is a small table that shows how the data looks like. We have prescriber ID, child ID, and as you can see, a single prescriber can treat multiple children. The age of the child, the medication they were on, whether or not the prescription has been red flagged, their assessment score for their needs and strengths, their race, and a neighborhood level variable like percent of people living below the poverty line. So we linked all 3 sources of data, fit a hierarchical logistic regression model to it. I'm not going to go into the details of the statistical model here, but you can feel free to read the paper to learn more about it if you're interested in implementing it. And this graph that you see here is essentially the final product. All the dots that you see on this graph are individual prescribers. They are de-identified. And the location of the dots represent the intersection between how many prescriptions they made and what their red flag rate was after adjusting for all the risk factors. You can see a horizontal black line here, which represents the average red flag proportion in the population. It is about 25%, which indicates that 25% of the prescriptions in this population are red flagged, and that black line basically forms a comparison line. Then we can see orange and red dotted lines, which represent 2 and 3 standard deviations from the black solid line. These are termed as the alert and the alarm zones. The red line is the alarm zone, which indicates that these prescribers should be alarmed at their prescription rates. And the alert zone of orange indicates that these prescribers need to keep an eye out on their prescriptions. We also see green dots and blue dots, which indicates that these are prescribers that are outlying, but in a possibly good way. Now, what you see here is a static figure, but what we provide the agency with is a dynamic figure where they can go ahead and click on, say, number 987 on the right dot there. That prescriber has a high number of prescriptions and falls into the red zone. So when they click on that number, and they can obtain all the details about who this prescriber treats, what medications they provide, and what types of red flags they have. We developed an interactive web page using Shiny app, mainly for 2 reasons. One is to make it easier for state implementers to interact with this plot and obtain more information that can translate to improvement. Second is for transparency of methods and ease of other researchers in child welfare to implement similar methodology. So to wrap this up, let me talk about challenges when linking data. Data linkage opens a whole world to examine policy relevant questions, but it can be challenging to balance privacy with data quality. Often the way the data is collected changes over time, and this leads to understanding how to harmonize data from several years. It is also very important that when research questions are answered through data linkage, we as statisticians be transparent about how the data linkage was conducted so that other researchers can reproduce this. So here is a reference to the article if everyone is interested, anyone is interested in reading it, and thank you for all of your attention.
Okay, I'm just going to stay here for a second while I do the wrap up so that everybody can see the paper. We are a minute over, but I want to encourage everybody to stay to hear Dr. Hepler, and thank you for joining our session.